Welcome back to MedCity FemFwd. I'm Marissa Plescia, reporter for MedCity News. Intimate partner violence is a serious public health issue and can have a major impact on health and well-being. That's why Intermountain Health has an initiative that screens women for intimate partner violence. Here to discuss this screening and why it's important, we have Dr. Audrey Jiricko of Intermountain Health joining us. Hi, Dr. Jiricko. Thanks so much for joining MedCity FemFwd.
Good morning. Happy to be here.
Yeah, so we're going to be talking today about Intermountain's intimate partner violence screening. But before we get into that, can you just tell us a little bit more about yourself and your work?
Sure. I'm from Indiana originally and attended college at Vanderbilt University in Tennessee, and then went back to Indiana for medical school and did my training in OBGYN at Riverside Methodist Hospital in Columbus, Ohio. And I practiced there for a couple of years in private practice before heading out west. And I came out to Utah over 20 years ago and joined Intermountain Health, and I've been practicing here ever since. And initially just started as a general OBGYN, my first 15 years in practice. And then some of this work that I'm doing with intimate partner violence sort of led me to working with other specialties, other areas of the organization. And even though I had I didn't imagine myself as doing administration at any point in my career, I sort of got pulled into it a little bit by doing some of this work. And so now I'm a senior medical director for women's health for Canyons region for Intermountain, as well as still practicing clinically.
Great, thank you so much. And as I mentioned earlier, you're offering this intimate partner violence screening. Before we get into some of the specifics of this, can you just tell me a little bit about when and why you began offering this screening?
You know, I trained a while ago, and I'm hoping the training is a little bit better through medical school and residency on the impacts of traumatic stress and health and wellness. But back when I trained, we really didn't get much information in this at all, other than, you know, if you have a patient that discloses sexual or domestic violence, these are things that are mandated to be reported. So more from like a legal documentation standpoint, but not from an all around, this is how these things impact women's health. But what I found is I was practicing, 10 to 15 years into my busy OBGYN practice. About 5 or 10% of my patients really consumed 90% of my time. So I was using all my OBGYN training and knowledge to try to figure out what was going on with folks. But I found there was this like subsection of my patient population where I just could not figure out what was going on with them. They were having health problems. I was spending a ton of time with them, doing a lot of studies, ordering a lot of tests, and still not being able to figure out what was going on with them. And around that time, the family medicine physicians had integrated mental health into their office and had psychologists come in and started screening for depression and anxiety. And they were getting a lot of success in that, improving health and wellness. So I figured, it couldn't hurt. Someone offered that, hey, do you want to try to integrate mental health into your office? So I took them up on it. And then we were shocked at how many people disclosed symptoms of depression and anxiety. So it just got me thinking, why are all these folks so depressed and anxious? So I talked to my friends who are social workers and psychologists to just really ask them, what is going on here? And they all said, hey, have you read the evidence of the links between traumatic stress and health and wellness? Things like neglect, abuse, assault, whether it's a history of that in the past or ongoing now. And so I went back to the books and sort of read all that literature and realized, wow, this is a missing link. We should be asking our patients about these things. And in 2023, the U.S. Preventive Service Task Force had a guideline that they produced based on that evidence that we should be screening all women of reproductive age for intimate partner violence and connecting them to resources, because all the evidence showed if we do that, we can decrease violence, we can improve health, and we can decrease healthcare costs. So that's when I realized, wow, we should be doing this on a routine basis, not just doing it with a specific subset population of patients.
Yeah, really interesting. Thank you for sharing that. And can you go into a little bit more detail about what this looks like and how it works?
Yeah, so it was a learning curve, and I will say one of the best things that we did when we looked into this is we started with our patients. We started with survivors of sexual and domestic violence first, and we did some studies and some interviews to ask people, hey, what went well for you in healthcare, and what sort of issues did you have and problems, and what would best state look like? So if you're a survivor of sexual or domestic violence, what would the best case scenario be as you go through that system? And the other thing is we really reached out to our local experts, our local advocates. So sexual and domestic violence advocates, our Utah Domestic Violence Coalition has been a huge partner right from the beginning. And I think the other thing that we did that was so helpful is I reached out to other systems that were doing this. So Dr. Bridget McCaw at Kaiser had a family violence prevention program and had over a decade of experience. And Dr. Jackie Campbell, a PhD nurse who's done a lot of research in this area. And so I was able to use these like decades of experience from these women to figure out how to do our workflow. And then we sort of set it up and started screening. And you know, one thing for me, I'll give you an example of when this was all coming around, and it was an aha moment for me, is I saw a patient of mine that I had seen for years. She happened to be a nurse that I work with, and phenomenal person, like incredible mother, incredibly smart worker. She had lots of support from various people, and I had seen her over the years, and she just came for an annual exam. So I asked how things were going, and she said, well, I'm going through a divorce. And I said, oh, I'm so sorry, I had no idea you were having issues. And she goes, no, it's the best thing that's ever happened to me. He was an extremely controlling and violent person. And she went on to tell me this, and I just thought, oh my gosh, how did I not know this? Like, didn't I screen you for this? And this is just makes me feel terrible that you were living in this situation and I had no idea. It's your biggest health risk and I had no idea. And she said, you know, you got to take the questions. The questions that we had in our office was, have you ever experienced um, emotional, physical, or sexual violence? And it was just like a check mark, yes or no. And no one ever said yes to it. She said, you need to get rid of that question. You need to study the power and control wheel. You need to read this book called Why Does He Do That? And this is how you should be asking this question. And so we really looked at the data and the research. And so our questions, instead of asking that sort of generic question, we heard from survivors that asking more specific questions like, are you called names, put down, and controlled? Are you hit, kicked, punched, shoved? Are you forced to do something sexually you don't want to do? Those kind of questions, survivors will say that's somehow easier to answer. It's a yes or no question. They don't feel like it's just broad and they're going to have to tell some sort of story. So those questions, I saw that patient on a Friday. I switched to the other questions on a Monday. And ever since then, every single day I work, I have people who disclose this. Whereas before I wasn't having any disclosures. So I think that's part of it, is the way we ask these questions. The other key thing we learned from our advocates is how critically important it is to set a framing statement. So when we ask people, we ask everyone and we let everyone know, hey, the reason we ask this question is so many people are impacted by it. It affects health. We have resources available. And then also a disclosure statement of what's mandatory to be reported. So we let people know before they even start talking, hey, we are healthcare providers. We are mandatory reporters. So if you tell us one of these things, we are required to report. So in the state of Utah, it's state dependent, but in Utah, If you tell us that your partner is threatening you with a lethal weapon, we have to report that. If you tell us that kids are witnessing or experiencing violence, we have to report that. Or if you come in with an injury caused by another person and you say, hey, this person did it to me and we're treating that injury. So those are the reportable things in Utah, in addition to vulnerable adult, assault of a vulnerable adult. So patients are very clear on why we're asking the question, what we have available to help them, and where this information is going to go. And that's another thing that's really helped us connect people to resources and have them disclose when they want help.
Yeah, and do you feel like that reporting requirement stops any people from sharing things with you, or in that case, does that then maybe then give them the resources and then they go a different route? How does that work?
I think generally what we've come to realize is that the goal isn't necessarily to get a disclosure. The ultimate goal is universal education on this issue and helping people understand that this is a common problem. About 1 in 3 women will experience a very unhealthy relationship in their life. And about 20 to 25% will experience severe physical violence in a relationship in their life. Very common problem, but it's also a preventable public health problem. So we know if we do these certain things that we can drive down violence and improve health. And so that just general information of you're not alone. This is a common problem. We need to talk about it. We want you to be aware of those resources because there are likely many, many people who don't disclose in a healthcare setting, but they're absorbing that information and they're taking it, or they're helping a friend or a neighbor or a family member. And I think that's most important.
Got it. Yeah, that's really important. And what are some of those resources that you're providing?
So I really encourage healthcare systems to connect with their state domestic violence coalition, because those people are really trained. They can offer trainings, they can offer support. And every step along the way, we've connected with them to say, are we screening in the right way? As we look at our electronic health records, is this safe for patients? And what do we need to be worried about as far as confidentiality things? So that's been invaluable. We're lucky in the state of Utah because we have a 24/7 link line, which we can use anytime, night or day. Healthcare providers can use it, survivors can use it, even people who perpetrate violence. If they want help, they could call this line and say, hey, where do I go? And then depending on the county you live on, and they can connect people. So that is our main thing. If we identify a patient in a clinic who discloses and wants help or connection, we always offer, hey, can we connect you? I also have learned my local places. So in addition to like the statewide resource, there are local places in various counties. And so if a patient is agreeable, what I do is I just pull it up on my phone, put it on speaker, and just say, hey, this is Dr. Jiricko. I screen all my patients for intimate partner violence, and I have this nice patient here who would love to meet with you and talk with you in the next 24 to 72 hours. And it's great because they can say, oh yeah, no problem. Do you want to do this over the phone? Do you want me to meet you somewhere? And then by the time the patient walks out of the office, I know they have a connection point and they're going to meet with that person within the next 2 or 3 days or so. Obviously, if it's more critical or serious, we can involve police, we can involve DCFS or adult protective services as needed. But I'm in a clinic setting and I'm screening. We're really trying to move this problem upstream so it's out of crisis mode. And so most of the time we don't need to involve those folks. It's just that connection to the advocate. The other thing that's super helpful, because a lot of people, probably 50% of my patients who disclose say, no, I'm not ready to do that. I don't want to do that yet. I don't want to talk with someone or meet with someone. There is an app called My Plan app, which is fabulous because you can just download it on your phone. It's really great for helping neighbors and friends and colleagues and family members who are going through this. And it comes up with a series of questions about the health of your relationship. and it connects you to resources and lets you know kind of how serious it is. I think in so many of these cases, we have just really strong, resilient people who are surviving and trying to protect their kids and do everything in their power to stay safe, and sometimes lose that awareness of how dangerous the situation actually is.
Got it. Yeah. And I want to also go back to something you mentioned earlier about how it's recommended to provide this screening to women of reproductive age. Why specifically just women of reproductive age?
Yeah, that's a great question, because in my world, we would screen every human because we know this unhealthy relationships impact health of potentially everyone. Men and women can perpetrate violence. This can happen in same gender relationships. This can happen at any age. The reason we're focusing on that right now first is because that's where the evidence is. So that's where the studies have been done. And that's where it's been proven to be helpful. But I think much more research needs to be done on men and the LGBTQ community and the elderly population. But this is where we're starting.
Right. Yeah. Yeah. So it's a process. You'll maybe move on to and expand
Yeah.
later on. Um, yeah, and you touched on this a bit in the beginning, but can you go into a little bit more detail about the link between health and intimate partner violence?
Yeah, this was the thing that once I learned this, I felt just I couldn't believe that I hadn't picked up on this earlier in my training, because it just made everything make so much more sense. Um, and it makes sense when you think about people who are victims of crime, whether that's child abuse, neglect, assault. I mean, 1 in 4 women experience childhood sexual abuse. 1 in 7 men experience the same. And being the victim of a crime doesn't have to ruin your life at all, but we know it is linked to other health problems. So things like depression and anxiety are linked with experiencing, surviving traumatic stress. Substance use disorder, because people will self-medicate sometimes. But there are also so many other health problems that we've seen this association with. Worsening cardiovascular disease, worsening asthma, things like non-epileptic seizures, chronic fatigue, fibromyalgia. And it's not something where it's just like, this is in your head, you were assaulted, and now, this is not a mental health problem. It's when you're the victim of a crime, it affects us. It affects our cortisol levels, our stress levels. And again, it doesn't have to ruin people's lives and health, but it's so important as physicians and nurse practitioners and PAs, other nurses and healthcare providers, to understand that link and how people are responding when they're um, recovering and processing and dealing with these health issues.
Yeah, really well said. Yeah, and since you began offering the screening, what impact do you feel like you've seen at Intermountain?
One of the things that I think it's so in line with what we're trying to do as a healthcare system. So Intermountain is a big organization. We're involved in 6 different states. The area that I'm responsible for as senior medical director is in 3 different states. We have over 200 physicians and APPs. And then we also work with over 200 OBGYN and women's health providers who are affiliated with us, who work out of our hospitals. And so, such a big, broad area to cover. We're really committed. Our mission is helping people live the healthiest lives possible. And it seems pie in the sky, but it really, instead of focusing on how many patients can we have in the hospital, how many people can we operate on, how many people can we do x-rays on, we're really thinking, how can we keep people at home healthy, doing what they want to do, and provide proactive care so people are living in the way they want to. And so it's right in line with our mission um, of really addressing these problems way upstream. And in our region, we've screened over 20,000 women so far. And what we find in a clinic setting is that about 20 to 25% of women will say, yeah, this has been a problem for me in the past. It's not a problem for me right now, but I have experienced this. And they're so appreciative that we're asking these questions. They'll just say, oh my gosh, nobody's ever asked me that before. Thank you for asking. And I have a sister or a friend or a neighbor going through this, and we can give them information that they can pass on to those folks. It's only about 1 or 2% of patients that we see will disclose, this is happening to me right now. We know those numbers are way higher, just because it's a numbers game and so many women experience this. But again, the goal is not to get people to disclose. The goal is to improve this education and awareness and help everyone understand where this information is. I will say one of the things we didn't expect, but we should have, is helping our own caregivers, our own nurses and doctors and uh, receptionists working in our clinic, our medical assistants, because this issue is so common. Intermountain Health employs over 60,000 people. And as we start teaching about this, educating to it, and screening patients, we've realized we need to take care of our own. So we've developed resources for our own caregivers who are experiencing this. And that's been really helpful for our team. And I think our employees appreciate it, that, you know, you actually care about my well-being too. And so our employee assistance program, we have people with experience in intimate partner violence and helping folks out so they can get connected as well.
Wow, yeah, that's really important. Well, I just have one last question for you. Do you know of any other organizations that are offering something like this? And if not, like what recommendations do you have for other organizations that want to offer something similar?
Yeah, I think Kaiser did such a good job with their family violence prevention program, and we were able to learn so much from that. And I would just say if other organizations are thinking about implementing this in a more routine way, focus on the resources first. So before you think about, okay, how are we going to ask these questions? How are we going to document these questions? What is this going to look like? The number one thing is, when you have a disclosure, what are you going to do about it? Once you have that, then that just empowers your team. And that's how we train as well. When we go into other clinics to train, the first thing we say is, these are the resources in your area. And we usually bring in an advocate from the local advocate from the local shelter to train with us too, so that we actually have a connection and they know who to call. That just empowers people, because this is a little bit of a scary topic. And some of our teams are like, oh, I feel uncomfortable asking about it. I'm not sure. I don't want to make it worse. It can be dangerous. But if they have the resources down, that is huge. I think educating about the dynamics of intimate partner violence and understanding why people get stuck in unhealthy relationships, and the things that we can do, which is believe them, trust their opinion on what they should do, respect their decisions about what they do, because many people are not wanting to leave the relationship, but we can still be a support to them and help connect them to resources. I have many patients who've been in very unhealthy relationship for years, and it may take 3, 4, 5 years, and then something happens, and they get connected and they decide to break it off. But we need to be able to support people's decisions about what they want to do. And I just think including those advocates and providing universal education is critical. I had a environmental service worker. I was working on a weekend and had this woman come up to me, and I recognized her because she helped clean our office. And she came up to me and she said, Dr. Jiricko, I just need to tell you that I just left a 20-year extremely abusive relationship thanks to the signs in your office. She wasn't a patient of ours. We had never seen her. She just cleaned our office, and she said, I saw that power and control wheel. I saw the CDC handout on healthy versus unhealthy relationships, and I just realized I don't need to live like this. And she used the resources that we had hanging in our office to get help. So that really made me feel great. And I feel like that's a perfect example of how we all just need to spread the word about about what's going on and how unhealthy relationships really impact our health and our family's health, and that there are teams of people out there willing to help out.
Yeah, so well said. This has been such an important and interesting conversation, Dr. Jiricko. Thank you so much for joining MedCity FemFwd.
You're welcome. Thanks so much for having me.